Hello, EMT-B class. How you doing? So we're back again for Chapter 18, Neurological Emergencies. Today, I'm not going to PowerPoint you to death. I'm just going to talk to you about neurological emergencies. You might appreciate that. I've had a busy week, so I'm sorry that this is coming out a little bit late towards the end of the week. My paramedic students at Atlanta Fire, they tested their psychomotor registry, did fantastic, crushed it, absolutely did a fantastic job. I was very proud of them. And that took up a lot of my week. And of course, I had to travel to lab Tuesday and Thursday. And I did one lecture on Monday, recorded. So I've just been super busy and I apologize for that. But the show must go on. So today I am going to give you the EMT-B spiel on neurological emergencies. So neurological emergencies have to do with things that are occurring in the brain, right? We're talking about the neurological deficits that can occur from certain disease processes. We're talking about a patient's mental status being changed or altered due to certain things. And we're talking about how you, the EMT, can recognize and therefore treat these things. The biggest and baddest and most deadly of these would be the stroke. A stroke is a cerebrovascular accident. Cerebral vascular accident. It's called a CVA. Fancy medical word for stroke is a CVA. Now, just like a heart attack, a stroke is normally a clot that has traveled or a clot that was formed in the brain. And what has happened is as the example I give a lot of, is if I tie a string around my finger, it'll turn what? Red, blue, purple, black, and it'll die. The tissue requires blood flow and oxygen content for it to function and continue its organic, its life, its livelihood, and performing its functions. Now, you can live without a finger, but if your brain stops working, you will not live very long. We need the brain to be perfused. Your brain needs a constant supply of blood and oxygen. Matter of fact, if you cut off blood supply to your brain for 10 seconds, you'll pass out. You'll pass out. So a stroke is a clot that is formed in the brain. Now, there are different types of strokes, and I'm going to talk about those here in a minute, but the one I'm talking about is called an ischemic stroke. Ischemic stroke. Ischemic strokes is when a clot has traveled to the brain, and we have a cerebral vascular accident, CVA, stroke, occur, and that clot, based on where it lodges in the brain, will cause neuro deficits to occur that we can pick up on. We can pick up on these things. So 85% of strokes are ischemic. There's a clot in the way. These form gradually and happen over time. Sadly, these sometimes are the calls I would get in the middle of the night, and they don't know when their last normal was. They don't know when his last normal was, so that's a problem for us. So these type of strokes can manifest with what's called hemiparesis, hemiparalysis, dysarthria. They can have facial asymmetry. They can have loss of motor strength on one affected side. They can have a terrible ataxic gait. Now let's break some of those terms down. When I say dysarthria, I'm talking about difficult speech. They cannot speak well because some of those lobes in the brain are being affected. They're going without blood flow. They're going ischemic. So that is one of the reasons that one of the tall tale signs of a stroke is that they are having trouble speaking. So let's talk about this. I'm going to pull up my little whiteboard. All right, so check it out. The mnemonic for checking for a stroke is we want to think fast. F-A-S-T. So face. To check for a stroke, we use what's called the Cincinnati stroke scale. It's kind of the EMS gold standard. There's other ones out there that are better that can tell you the exact area the brain's doing it, but we don't have time for that. Again, when it comes to a stroke, because that brain is being forced to endure not having enough oxygen, time is money, time is brain. We've got to get moving and grooving. So as soon as you recognize a stroke, you need to be getting up out of there and heading towards a stroke center. Don't head to the closest center or closest hospital out of fear. Your patient needs a stroke center where reperfusion can occur. So if we have a clot causing hypoperfusion to that area, causing ischemia, we need to reperfuse that area. One of the ways they do that is through tissue plasminogen activator drug, which is a clot buster, TPA. Some patients will need surgery, some patients just need the clot buster drug, but they have to fall within certain criteria to actually receive that drug. So we check the Cincinnati Stroke Scale, we check their facial symmetry, make them smile. All right, ma'am, smile for me. And if their face is symmetrical, both sides will lift up. If it is asymmetrical and one side's drooping, that is a bad sign. Now, there are diseases and processes that can affect and mimic a stroke, like hypoglycemia. Low blood sugar can mimic a stroke. A condition called Bell's palsy can mimic a stroke. But we have to be thorough, we have to check. And if a patient has any one of the stroke signs, there's a 72% chance that they're having a stroke. It is much better for you to call the stroke alert and be wrong than not call it and the patient be having a stroke and they can't get reperfusion because you delayed them. So facial symmetry. Arm is A. Now, how do I check for arm? What am I doing with arm? You just said arm, Josh. What does that mean? So we have the patient hold out their arms like this, right? Close your eyes, ma'am or sir. As they hold out that arm, if there is weakness on one side hemispherically, that arm that is weaker will drop without them knowing it. I also like to still have them squeeze my fingers. If there's a grip strength issue with their motors, then I will know it pretty quickly. But for the purpose of just the Cincinnati Stroke Scale now, we're only going to check face and arm. Face and arm. So face, arm drift, facial symmetry, arm drifting, and then we check their speech. We check their speech. How do I do that? We'll talk to them, make them talk to you. If a patient is having a stroke, they won't be able to talk very well. It'll sound like they got peanut butter in their mouth. And the age-old saying we in EMS have gotten them to say was, you cannot teach an old dog new tricks. You can't teach an old dog new tricks. We have them say that, and we can gauge how well they articulate the words. Now, you need to be careful with this because when I was working in South Georgia, down in Hicks Sticks, where I'm from, there was this one patient, I thought he was stroking for a minute, but his brother was like, I asked his brother, is he okay? Is he within his normal? Does he talk like that normally? Oh yeah, he talks like that normally. They got no gas in it. Okay, so he wasn't actually stroking, that was his normal. So that needs to be part of your assessment there and finding out if they are deviating from their normal. Their speech should be articulate and it should be well-formed, and you should be able to gauge from it if they are possibly having a stroke. Even one of these signs or symptoms right here being present indicates the high possibility, 72%, that there is a patient having a stroke. This is paramount because, again, I'd rather be wrong about them having a stroke than them have one and me miss it. We can't afford to miss it on this, because if a person has a stroke and they're not treated, that side of their body that's weak now may be paralyzed later. We don't want that from them. We want reperfusion therapy as fast as possible so we can do what? So we can get them there. They'll do a CT scan to see what type of stroke's going on. Is it ischemic or is it hemorrhagic, which we'll talk about here soon. Based on what the CT says is the treatment they get. Based on what the CT says, that's the treatment they'll get. We need to find out and make sure. But before I get to that hospital, I've already called a stroke alert. Hey, this is Med Unit 1 en route to your facility. I have a 69-year-old male patient with possible stroke symptoms. He has facial asymmetry and arm drift. At this time, vitals are as follows. I'm going to go ahead and call a stroke alert, blah, blah, blah. So as that happens, the hospital will then allocate resources. And I can only tell you what the best response I ever saw was the one at Grady Memorial Hospital in Atlanta, Georgia. And that is, I'd call a stroke alert, even if it was 3 o'clock in the morning, stroke team would be at the door waiting. Are you the stroke? Are you the stroke? Are you the stroke patient? And when you finally come in, you're the stroke patient. Yes, sir, it's me. And they would do their thing and perform doctoral sorcery they do their own stroke assessment, take us to the CT scan them up, and if they needed treatment, they would be done lickety split, fast and quick. So all always transport to a stroke center. That may mean you get off late. That may mean that, it's uncomfortable and you have to be in the back with the patient longer. But man, you got to always remember and remind yourself, if this was my grandma back here, but I want some medic cutting corners and taking her to the closest facility because I'm scared to be back here, or do you want him to hump, or would you want him to hump it over to the stroke center and do what he's paid to do and be there for his community and treat that patient like it was his own grandmama? So that's what we want. So if you ever have to think about it, then you know you're in the wrong, right? So do the right thing, be ethical, be moral, keep it legal, and take your patients where they're supposed to go. The last component of the FAST mnemonic here is time, baby. It's time. So what about time are we talking about? So we evaluated a patient for facial asymmetry, arm drift, and speech dysarthria. They can also display what's called aphasia, which is they're having difficulty getting words out. There's expressive and there's expressive and reflective aphasia, meaning basically they're either having trouble getting words out or they're having trouble hearing you. So basically, you could be talking and you sound like Charlie Brown's teacher, but they can talk perfectly, or they can hear you perfectly when they try and speak. It doesn't. He's trying to say, "Ooh, this is a nice Coca-Cola can," but he's actually saying, "Ooh, that's a weird looking lint brush or something." So they can't say what they're actually trying to say because their brain is, again, being ischemic, and those nerve synapses are not firing like they're supposed to. So face, arm, speech, and time. Time is of the essence because time is money. Time is brain, right? So there is a window of time and opportunity for these patients to get that reperfusion clot buster therapy. Now, for many years, it was 3-hour window. That means that their stroke symptoms have started within 3 hours. If they went past the 3-hour window, a lot of neuro interventionalists would not treat them with a tissue plasminogen activator. They would not give them the clot buster because they are outside the window. And at this point, it could cause more harm than good. And again, this is for ischemic strokes. Ischemic strokes get the clot buster. Now, the 2020 Advanced Cardiac Life Support update, the ACLS updates this year, as well as last year, have stated that the new stroke window has moved from 3 hours to 4 hours and 30 minutes. So if their symptoms have started and occurred within 4 hours and 30 minutes of the time you get them to the hospital, then they can receive possible treatment for that. Again, time matters because that's more brain loss, but also it matters because of what treatments they can receive. So as soon as you recognize a stroke, huff it, move it to the hospital. Now, let me give you a forewarning. Let me say it 50 times for you. I'm not going to actually say it 50 times, but I'm going to repeat it a lot. Every stroke patient, you check a blood sugar. Every stroke patient, you check a blood sugar. Every stroke patient, every altered mental status, that's even better. Every altered mental status patient, you check a blood sugar. I would even go further to say every patient you pick up, unless they can tell you that they don't want you to and refuse, I would take a blood sugar on. I would put them on a 12 lead for your medic. There's nothing wrong with taking an extra 30, 40 seconds to put a patient on a 12 lead, or another 20, 30 seconds to check their blood sugar. These are how you find the little old lady who just, I feel weak today, baby, God, dog. And then you put on a 12 lead. No wonder you're weak. You're having a heart attack. Good God. Or this is how you find the 22-year-old male you pick up for just puking his guts out. He's sick. He's dehydrated. And he don't know what's wrong. I've been sick for 2 days, man. I don't know what's going on. You check his blood sugar. Dude, this thing's reading high. Do you have diabetes? He's like, no, I ain't got diabetes. Well, you sure? And we found out that he had an undiagnosed type 1 diabetes. It had never been like a real issue, but there it is. Not enough for them to catch it, I guess, or maybe he didn't go to the doctor or whatever. I don't know. So it's always good to be as thorough as possible. Be thorough. Don't miss anything on these people. You got to remember about you, your kids, your mom, your dad, your wife. If you had your family member back there, again, this is just to encourage buy-in. Treat that patient like family, because if it was my daughter back there, I'd fight tooth and nail. I wouldn't skip a step. I'd go head to toe, be systematic. It wouldn't matter how tired I was. If I pick up your daughter, that's exactly how I would treat them. Or your son or your grandma. That's my granny right there now. Now, when the bill comes due, you can have her back. But while she's in the back of that ambulance with me, she's treated like family. And that's how I want you all to treat your patients from now on until always. Now, what if some of y'all go and become doctors and nurses and other things? Always the same mindset. Always the same mindset. You treat people like family. If you're starting to be mean and discourteous to people, you need to reevaluate your career choice, or you need to take some vacation time. You're starting to experience some burnout, and maybe you're not doing enough self-care. I am the world's worst. You guys know that I work 3 jobs, and I'm taking 3 university level classes here. And like last night, I got home from lab. I live down here in South Henry County, and our class is up here in Roswell, right? So that's an hour and 10-minute drive. I got home like nearly at midnight. I had to get up and work again today. I had stuff to do this morning, and it's been like that for a long time. I'm the world's worst, so I'm not going to be a hypocrite and say, don't work so much, man. But I like my things. But I do think that now that my both my paramedic classes have finished, one, I can focus more on you guys. I'm not taking another paramedic class for a month or so. 2, I'm going to start taking more of a step back. I'm going to start taking better care of myself. I used to be in really good shape, and I have not been taking care of myself. I have only made 1 or 2 training days happen. And to be, in EMS and firefighting and all that stuff, you got to be fit, because my liabilities are your liabilities if we're partners, right? So please make time for that. That was just a rabbit trail. I did not mean to go down, but you kind of got to roll with it sometimes. So stroking, face, arm, speech, time, face, arm, speech, time, think, fast, fast. Any altered mental status, perform a stroke scale, 12 lead, blood sugar. Be as thorough as you can be. We have so few diagnostic tools in the pre-hospital environment, and it would behoove you to always check everything you can and be as thorough as you can. And if you ever get stuck, make a phone call, man. Don't let pride be an enemy of the good of your patient. I'd rather look stupid for a minute than hurt a patient. I really would. I hope you feel the same. All right. So we've talked about the ischemic stroke. The ischemic stroke is, again, a clot has traveled by most of the time it travels from the legs. Most of the time it's from the legs, but it can travel from anywhere. The legs will have what's called DVTs in them, deep vein thrombosis. Now, the airport division of the fire department here in Atlanta, they run a lot of PEs, a lot of strokes, and a lot of heart attacks. Think about this: 80-year-old grandma, she goes and rides on a 12-hour flight. She ain't got up once. 12 hours is up, she stands up. That deep vein thrombosis in her legs breaks off, travels up here, and causes problems, stroke problems. Happens a lot, happens very much. So a DVT is a very usual customer for strokes. Another one is having a heart abnormality called atrial fibrillation, especially new onset atrial fibrillation. So this means that the atria that sit above the ventricles are no longer pumping like they're supposed to. They're now quivering. They've got multifocal atrial pacemakers going off, like they're just firing all over the place. There's pacemaker cells just firing, depolarizing, and the atria is no longer pumping. It's quivering. It's twerking on you. So it's fibrillating. So because it's fibrillating, blood's not being pumped out. Now, the blood does eventually get out of there, but some stays in there. And when blood sits, what does it do? It coagulates. It forms clots. And this is one of the reasons that we don't really cardiovert atrial fib with RVR, AFib with RVR, because it can just throw clots everywhere. We want to be careful and, again, do no harm to our patients. So strokes have a bunch of different places they can come from, but it's mainly 85% of the time a clot that formed there, and a thrombus formed where it is. An emboli travels. Remember, emboli embark. Thrombus, he sets up shop, builds his house there, and he stays there. So whatever the emboli or the clotting, whoever caused the clot is, there is a clot. It must be either pulled out, cut out, or blown out by some medicine. So we've got to get them to reperfusion therapy. So continuing on, that was an ischemic stroke. Another percentage of strokes, the 15%, is called hemorrhagic. Hemorrhagic stroke is when a vessel in the brain pops. Now, we talked about the water hose example I gave. You leave a water hose on too long and it's got a high pressure flow on it, that water hose will develop that. Let's do the whiteboard again. I actually like that. Now, I'm a terrible drawer, as you know. I'll get over it. So we got the vessel here, right? All right, and so the vessels have different layers to them. Without getting too in depth on a EMT-B class, there's the tunica intima, the tunica media, and the tunica adventitia of these arteries. And those guys will start to, the first layer, intima, the innermost layer will start to tear. And that tearing will then allow blood to flow. Instead of flowing, this way like it's supposed to, it'll get in this lining and start to form a titty. This titty is called an aneurysm. Now, this can be because of congenital weaknesses in the vessel walls, or it can be because how it is most of the time, honestly, it's because people don't take their dang hypertension medicine. People do not take their high blood pressure medicine. And then again, like we said, this high pressure system, blood flowing down here, it's always high pressure. This weakened area of vessel wall gets out and forms a titty or an aneurysm, whatever it takes you to remember it. And it gets bigger and bigger until what? It pops. It pops. Now, the difference maker between a ischemic stroke is it's usually a gradual thing that happens. The aneurysm or hemorrhagic stroke is usually like a there it is thing. They still exhibit the same stroke symptoms, but they will usually complain of hypertensive crisis symptoms before they have the vessel explode, like blurred vision or a really stiff neck or a headache in the back of their head. Now, the headache is a key registry buzzword, but also I've heard it in the streets before when I was picking up patients. And it's one of the ways you can kind of differentiate between a hemorrhagic versus an ischemic stroke. They'll complain of the worst headache in their life. The worst headache in their life. That is a registry buzzword. They use it a lot, but also I've had patients actually say it. Man, it's the worst headache in my life. And then again, it's usually a quick thing like that. Now, the problem with this one is also with all that blood leaking out, it's causing a stroke, right? Stroke symptoms are going on, but another thing can happen is eventual increased intracranial pressure. This patient cannot have that TPA, that tissue plasminogen activator. It can't have the clot buster. This is why they CT before they give drugs to the patient. If he's got a hemorrhagic stroke and he's got a brain bleed going on, we give him a clot buster, it's going to make it way worse. He'll be dead. It'll be like a bullet to the brain. So he doesn't get the TPA. He doesn't get none of that stuff. The hemorrhagic stroke needs to have that aneurysm clipped by a surgeon. Okay, have it clipped by a surgeon. This patient will probably need a craniotomy, to be honest. And you have to take these patients to facilities that are capable of delivering these type of interventions. So a stroke center with a neurologist there. Now, the challenge it presents is, working in Atlanta, we're only like at best 20, 25 minutes from G Unit, from Grady, or AMC. Both are level 1 trauma centers. They both have stroke capabilities, heart, chest pain capabilities. You could just take them just about anything. If I was ever in doubt, I'm like, Grady can handle it. And that was the blessing of being there. But I started my career in South Georgia, down in the farmland and the sticks. And there's differences between them. I love big city EMS. I found my tribe at Grady. I really did. And I love them very much. But, there was something very quaint and very family oriented about that South Georgia team of EMS professionals I worked with. It felt like family. It really did. We would cook and eat together. We would help each other with things. And if I needed help moving, they'd come do it. And it was just much more tight knit group versus the big city stuff where there's so many of you. It's really hard to really, get as close as I used to want to get. I don't like people now, but I used to like people. But anyway, down in South Georgia, if I had a stroke patient, the nearest stroke center is like an hour and 15, 20 minutes from me. And if time is brain and time is money, and I can't perform neurosurgery in the back, and I don't carry TPA in my back pocket either. I've got to get them to a stroke center as fast as possible. So I can either huff it and ground and pound and take them myself in the ambulance, or I can call a helicopter. That's always an option. And it's something you need to think about is a lot of you are from the big city, and this is what this company that is putting on this EMS class is about. It's the big city EMS kind of stuff. It's Central EMS, and they do a fantastic job of what they do, of course, but you got to remember that to be an EMT, you have to pass a national registry test. There's going to be big city EMS call scenarios on there, but there's also going to be Jethro, flip this tractor again. So you got to be ready for all of it. You have to study and prepare for all of it. So in South Georgia, if I had a stroke patient in there and it was possible, I'd fly them. I would call for a helicopter. Yes, dispatch, get me a bird in that ear. And I would meet them, and they could be at the hospital in 15, 20 minutes of flying versus my hour and 15, 20 minutes. You know what I'm saying? So this is for the patient's benefit. Now, if there was a cloud in the sky, some of the pilots wouldn't fly. And I'm not mad at them because they know more about that barometric pressure stuff and all that flight stuff than I do. If they don't think it's safe, I'm sure it's not. It would just be very frustrating as a ground medic at the time. Take this hour drive and it delayed care for my patient. But I know safety comes first for us and for them, so I'm not mad. So I would have to huff it over there and just hope I can make it in time for them to get reperfusion therapy. But if I can't, then I can't. I can't beat myself up about something I can't control. I got the call when I got the call. I found the stroke as early as I could, and I got moving as fast as I could. So if you ever have a call where you have some self-doubt come in and you're like, man, I should have done that. What could you possibly do? Don't beat yourself up over any call. If you did your best, do the best test. Did you do your best? Was it in God's hands and not yours? You have to let it leave it on the table there. So the next thing we want to talk about is going to be another form of a stroke. This is called a TIA, a transient ischemic attack. A TIA is a mini stroke, beta stroke. So a TIA is a transient ischemic attack, TIA. So a TIA is a patient that will exhibit stroke symptoms that will resolve themselves within 24 hours. So basically, and I've seen this a few times, they call me patient stroke. And when I get there, they're not. But everybody is describing perfectly stroke symptoms and this and this. And the patient's like, I don't know what happened. I felt kind of funny for a minute. Or you get there and they're still having a stroke and you're like, yeah, stroke alert, let's go, come on, go to the stroke center. And then as you approach, they're like, where am I at? Hey, you couldn't talk a minute ago. What happened? I don't know. I feel like I shouldn't be in an ambulance. So I was like, sound like you shouldn't. And then those stroke symptoms just go away. Is it a embolism that traveled up to the brain and just got stuck for a minute and then flew on about its business? Since I don't have X-ray vision, I can't tell you, but it's a transient ischemic attack. It's a mini stroke. It's a stroke that has symptoms that last for maybe up to 24 hours, but maybe just a few hours, or maybe however long it takes the reperfusion to occur naturally in the brain. The onus of that is that TIAs or mini strokes are precursors to a big stroke. It's like ringing the bell, like ding, 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 ding. Big stroke coming soon to a theater near you. So if you ever have a patient with a TIA, make sure you tell their family that maybe some diet, lifestyle changes, and blood thinners or whatever they need to do with their cardiologist, and see what the neurologist tells them to do. They need to be doing it. Don't play with this. Make some changes because it is a precursor to a big old stroke coming soon. So again, if you have any questions about today's lecture, feel free to email me. We'll get back to you and knock them out. Also, you can bring, if there's anything you don't understand, make a flashcard of it and bring it into lab this week. We'll definitely go over it. So the next thing we're going to talk about is called a seizure. A seizure. So some people have seizures because they are they've had such a low blood sugar. Some people have seizures because there's too much pressure in their brain and they start to seize. And then a lot of people, the most common cause of a seizure is epilepsy. Epilepsy. People have epilepsy. Epilepsy you can think of as like an electrical storm in the brain. Something in here is not firing right. And when it starts to misfire, the body will respond in one of two ways, or one of several ways. The ones we're going to talk about are with a full-blown tonic-clonic grand mal seizure or a absence seizure called a petit mal. Now let's break that down. Grand mal seizures are full body seizures where the patient's doing the whole traditional that you would think of seizure movements. They're like shaking, foaming at the mouth, and they've got incontinence where they pee or poop themselves. Their jaw might be clenched down, and it's usually a very violent act. That happens. So the seizure is a grand mal when they're doing that whole movement thing. That is called the grand mal. So hopefully that patient stops that within 2 or 3 minutes, because while they're seizing, they're burning up a lot of oxygen and a lot of energy in their bodies and muscles. One of my best friends growing up, he's had epilepsy and he still has it. I don't even think he can drive now because he's had a seizure while driving. So it's an extremely sad and terrible thing. And I remember him telling me one time that he, after he had a seizure and he wakes up and he's talking and stuff again, he is exhausted. He like sleeps for a day or two because he is just so worn out. Just think about shaking everything you got as hard as you can, as many times as you can, and it'll wear you out. Another problem with seizing or a patient having a seizure is that they're not breathing while this is happening. So a seizure can become an airway compromise very quickly. So any patient that you have that is seizing near you or around you, if you're a BLS unit, you don't carry the right medications to stop it. But what you can do is mitigate the circumstances for this patient. Turn them on their sides and let them seize. And then you can also try and manage their airway. Give them some oxygen and make sure you've got an ALS unit coming to you. So the paramedics, we carry what is called anti-convulsant medications in the form of a benzodiazepine like Versed, Valium, or Ativan. These drugs, when administered, will stop those seizures. Now, there are some side effects to the drugs to be watching out for, but since we're not in paramedic school, this is EMT school, I'll not dig into them. I have a habit of doing that. I'm going to stop myself. So the seizure patient, protect their airway, turn them on their side, let them seize, don't let them hurt themselves. I got there one time, this fire Jake was out there, man. Patient was seizing, he was letting them do it, and the patient was hitting their head against the floor of concrete. It was cutting their face up. And I'm like, dude, hold his head. Upset me. So hold them on their side. Don't let them bang their head against the floor, and then support their airway. And hopefully you can get a paramedic there to stop it. But most seizures self-correct within a minute or two. When they don't self-correct, when they don't stop seizing, when they have more than 2 or 3 seizures back to back to back to back, and this continues to last, this is called status epilepticus. That patient is in very serious duty. Status epilepticus is a condition that we have got to stop. Because again, the airway, they're not breathing, they're burning up all their glucose in their muscles and creating a lot of acid from the lack of aerobic metabolism that they could have. So it's very dangerous and deadly, and the patient could arrest that way. We don't want that to happen. So we are going to act upon that quick. Again, as an EMT-B, you need to be calling an ALS unit if you already got one. Turn them on the side, protect the airway, get that thing moving and grooving. So how do a lot of the patients that have epilepsy, they know that they have epilepsy, and they can sometimes know when a seizure is coming. They know before it happens that a seizure is coming. It is called an aura, whatever. I ain't talking about chakras or healing crystals, anything. Now I'm talking about the patient will know it's coming by either maybe a sound that their ears start to ring, or they'll taste a funny taste, or they'll smell a funny smell. And every time they smell or taste or hear that, whatever that stimuli is, they know a seizure is coming. My friend I was talking about would always taste like almonds in his mouth. Ooh, almonds. Oh, God. And he would start seizing. So that's not funny. Okay. So he would taste almonds and he would know it was coming. So an aura is a precursor, a kind of a warning bell, like, hey, you're about to seize, bro. So before the seizure, they have the aura. During the seizure, they have that full tonic-clonic movement. So let's observe. Tonic movement would be what? Be kind of like a charging. They'll contract like this for a second and kind of be posturing, and then they'll start the full clonic motion where they start to seize. So grand mal is when they actually seize with their whole body, right? They have the tonic where it's drawn up, charging, and then we'll call it charging it. And then they have the clonic where they're letting all that go. Before they'll have an aura. Now, excuse me, not corona. After a seizure, a patient will have what's called a postdictal state. They'll be in a postdictal state. The patient will be very lethargic, may be confused, may not know who they are, where they're at, because they, again, their brain was just going without oxygen for a minute or two, and they, oh, where am I at? Dang, thanks in here. But the patient will not know who they are. They'll be very sleepy, very tired, and acting kind of funny. That is the postdictal state. That is the after the grand mal seizure. After the grand mal seizure, that is what they'll be doing and what they will seem to be doing. Don't be surprised by it. And that is what's going to happen. So there are another type of seizure called the petit mal. Petit mal, grand being the big body shaking. Petit mal is a fancy way of saying daydreaming or the absence seizure. The patient will be sitting there talking to you and suddenly just stare off into space. And again, that electrical storm in their brain's going off. They don't have a physical like body seizure, but in their mind, there's a lot of electrical activity going on, and they'll space out maybe a minute or two. Hey, dude. Huh. So yeah, like I was saying, petite mals do happen, and I've seen some of you in our lab class when I'm trying to tell you something. It looked like you're having one. Like, you space off. There's a difference in daydreaming and actually having a petit mal seizure, one being more serious, of course. Not a whole lot you can do about these other than just note that they're happening and protect the patient's airway, keep them breathing, keep their circulation moving. So supportive care and ABCs, really. The next thing I want to talk about, of course, will be headaches. Now, I don't want to say this is a hot button topic for debate, really, but maybe it's the worst. So if a patient calls you for a headache, I don't want you to be a douchebag to them, okay? This may be the worst headache they've ever had in their life, which could indicate something worse is going on. It could be a real full-fledged migraine. It could be a sign or a symptom of something else. Let us not get in the habit of downplaying, discounting what our patients say. We just don't know because, again, we don't have X-ray vision. We don't have labs. We don't have CT scans on the ambulance. We just got a gut feeling. And I told y'all the story of the man I used to pick up all the time. He was a homeless dude from Americus, Georgia. And he had chest pain every week, 3 or 4 times a week. Now, a lot of the other medics, they were like, all right, come on, get in, man. Let's go in the hospital. And all he really wanted was to flirt with the nurses. And he just wanted to get a sandwich. I ain't mad at him. But if you call me for chest pain, I'm going to treat you for chest pain. Because the only way to really, really verify if a patient's having a myocardial infarction or not, or a heart attack, is for labs to be drawn, for their blood to be taken out, squirted into this chemical reader, and for us to see what his troponin levels are. If the heart is under stress, it releases chemicals saying, I'm under stress. And you can read those chemicals. That's the only way. So any medic or EMT out there needs to remember that and realize that we don't know. I promise you, you've been wrong before. Don't take the chance. Always act like the wolf is at the door. The little boy that cried wolf, wolf, wolf. Kidding. One day there might actually be a wolf there. Don't let him catch you and that little boy slipping. Little boy's playing games, but don't let him catch you slipping because he might get you too. I would hate for you to get in trouble for negligence. But one day the guy wasn't playing. I got there and I could just tell something was different. And I've told y'all this story before, but I'm just driving it home again. Something was different. I felt it in the air. I seen it on his face. I put him on the 12 lead and he was having a myocardial infarction, ST elevation. Took him to the hospital where the cath lab was at. Got him treated. They put stents in. He lived another 10 years. Always, always take your patients seriously. You could be wrong. Have the humility to think, I could be wrong. All right, so last thing I'm going to share with you today about neurological emergencies is you can't see inside the head again. So there's going to be patients you can't figure out, man, and that's okay. You can't figure out all the patients. So what I got for you here is a mnemonic that's very helpful, and it's an EMS mnemonic that we use. It's called Aeiu Tips. Aeiu Tips. Now, if you have a patient with an altered mental status, it is going to be one of these things that is causing it. Is it alcohol, acidosis, alkalosis? Are they just drunk and passed out and you can't get them awake? Is it an endocrine disorder, electrolytes, or encephalopathy? So endocrine would, of course, be something like, maybe diabetes or Cushing's or something like that. That's just, knocking them down right now. Electrolytes can cause it. Encephalopathy. So encephalopathy would mean all right, give me a minute. A disease, structure, or any process that is impairing the normal function of the brain. There, I think that's it. That's encephalopathy. Insulin. So overdosing on insulin would drop your blood sugar. You could have an unresponsive patient. Opiates. Uremia, a raging urinary tract infection or a UTI can make a patient be altered or unresponsive. Trauma, head injury, being in shock. Eye, intracranial pressure, infection can cause you to be unresponsive, right? You can have a septic patient whose blood pressure is on the floor because they got so much bacteria in their bloodstream and it's lowering their blood pressure, and here they are and they're infected and they don't have enough blood pressure to stay conscious. Poisoning or psychiatric. It could be a psychiatric thing. They could be for the poop. With those sternal revs for them, baby. It could have been a bad seizure, and it could have been a syncopal episode. Aeiu tips. I would commit this to memory. If you've got an altered mental status patient or an unresponsive patient, you can start checking these things off. Seeing, is he drunk? Do I smell alcohol? Is there bottles around? Is it opioids? Is it like a bunch of needles laying around? Or they got pinpoint pupils? I'm looking for causes here. And if I find the cause, it's very possible that I can fix the cause. Now, there are going to be patients you cannot figure out. I'm sorry. There have been patients I couldn't figure out. They're unresponsive, right? And I've checked every vital sign. Their blood sugar is perfect. Their 12 lead is good. Their eyes are pearl. They're breathing fine. They got a good O2 set. So everything's great, but I can't wake them up. And I gave them a sternal rub to see if they were faking. I weigh 275 pounds, and I put it on them like, yay. Not to try and hurt them, of course, but is this for real? Oh, yeah, for real. So that's where, I don't know if they still do this in some services, but the services I worked for had the Coma Cocktail. And you can't give any of this, but I just want to tell you about it. The Coma Cocktail was, if you had an unresponsive patient you couldn't figure out, we would give thiamine, D50, which is sugar, and Narcan. And the Coma Cocktail would be a way of kind of like, hey, maybe this will work and wake you up. If not, I'm just going to keep you alive till we get to the hospital and they can do some more in-depth diagnostics. I don't know if a lot of places are still doing the Coma Cocktail. I know over the last couple of years of my career, I didn't like giving things without having a reason to give things. We don't give things all willy-nilly. So let's say a patient's having trouble breathing. Do I just automatically stab them in the chest with a needle in case they have a tension pneumothorax? In case there's air trapped over there? No, I don't do that. I have to have clinical reasoning behind that. So I don't think a lot of places are doing that anymore. They might be. I don't know. I just feel like it bears mentioning at least. All right. So guys, that's going to be it for the lecture about neurology and neurological emergencies, at least as far as the EMT-B curriculum is concerned. Expect some neuro questions on your upcoming little quiz you got this week due by Sunday night, or you turn into a pumpkin. What kind of shape does a pumpkin make? There you go. This week, coming up on the week 7 of our little EMT-B class, things are going to change a little bit. I got a couple curveballs coming your way. I'm excited for lab this week. We're going to get into anaphylactic emergencies. We're going to get into toxicology, gynecology. Some of y'all going to deliver a baby this week. Not a real baby, but like a fake mannequin baby. Still counts. So we're going to get into that this week in lab. It's going to be a lot of fun. So any questions, comments, concerns, email me. Y'all have a blessed week, and make sure your assignments are due by Sunday at midnight, and I'll have a good one.